it is my pleasure to introduce Dr. Catherine McDonald. Um, Dr. Catherine McDonald is a Bloomberg Distinguished Professor at the Johns Hopkins University. She serves as co-director of the Johns Hopkins Center for Diagnostic Excellence. Dr. McDonald previously led the Center for Health Policy at Freeman's Pogli Institute for International Studies. Her research considers what makes for high quality and safe healthcare delivery systems. Thank you, Dr. McDonald, for being here.
Thank you, Dr. Raghavan. This is just a marvelous conference, and I'm very delighted to be part of this implementation session for this model of care. I am going to be presenting kind of the big picture on the challenge of coordinating care and coordinating anything that needs to be done to implement a new model. So I'll give you some of the scaffolding for that. I don't have anything to disclose, and plan to go through basically three main learning objectives here, taking into consideration a systems view of stroke care continuum, asking the question, what is care coordination, and then how to use ideas about care coordination to build all the bridges that are necessary across the stroke care continuum, which we've been seeing many examples of the detailed work that's required. I'd like to start by asking everyone to think about maybe the three words, and here's a list of possibilities, which strike you as most applicable to any coordinating of care that you're involved in, or coordinating of the structures behind the care, or coordinating of the way to assess the care. Anything that you're part of, look at this list and think about what the three most salient words are. They all relate to coordinating, but some may relate more and some less, depending on what your particular activities and function is. In trying to at least set the framework about what coordinating care might be, I want to expose you to some work on looking at many definitions of coordination of care. This was work that was done in the early days of coordination of care being a national priority. We, as a research team, looked for how care coordination has been defined, and there were over 50 definitions available. We ultimately developed a definition that's widely cited by the Agency for Healthcare Research and Quality. So in order to think about care coordination, to improve it and to achieve it, this definition has been used fairly frequently. And I've bolded some of the aspects of this definition that combine important elements from the work of looking at other definitions. So deliberate organization of patient care activities between two or more participants, including the patient, facilitating the appropriate delivery of healthcare services, marshaling personnel and resources to carry out all the activities. And this is managed by the exchange of information among participants responsible for different aspects of care. It's a fair number of words, but as you can see, it gets at the elements of what it takes to coordinate care and reflects the 5 common elements that we were able to assemble from these definitions. The idea that there's numerous participants, the idea that these participants who are coordinating are dependent on each other to carry out their disparate activities in patients' care, that there's adequate knowledge about one's own role and others' role and the available resources. So roles and resources is going to be a theme that I'll keep speaking to. So if you're involved in customizing some of what you're hearing here today into your own setting or evolving this work within, say, the Hopkins setting, thinking about what way you think about the roles that are involved and the resources that are involved is a fundamental aspect of getting the coordination working. It's all done in terms of relying on exchange of information. And then I want to really highlight this last one, that's not part of all the definitions, interestingly, even though if it's implicit, it's part of it, but making it explicit is necessary. So the integration of care activities has the goal of facilitating appropriate delivery of healthcare services. So we've heard today about, the right treatment, the right intensity, the right time. This is one of those ways to articulate the goal of what this model is trying to do. Now, what is the care continuum? Again, just setting the stage. We can articulate the various elements of a continuum. The whole is that there's something continuous that's being linked together, paths that need to be linked together, and that these parts can't be separated and still have the same effect of the whole continuum. What I want to highlight too in this definition of nurse researcher Jerry Lamb is the idea of extensive feedback loops. What we were just hearing about in terms of the information systems behind the learning network, that there's an ability to continue to feedback in this exchange of information as part of coordinating care across a continuum of care. In terms of systems of care, stroke is just a lovely example of a very complex continuum of care and a need to actually focus on what is the continuum and how to navigate that continuum. That this well-designed stroke system includes education, coordination, facilitation at each of these stages that are part of the entire continuum, and that patient outcomes are dependent on the system investments throughout and the integration of those investments. I would further call back to the report that recent article mentioned in terms of a task force to develop stroke systems. And this is, of course, a session on much more detailed work over time. But coming back to the fundamentals, right in this circled area, it talks about how there can be fragmentation. And this task force was gathered to address the current fragmentation. Fragmentation will always exist. And the challenge of thinking about the continuum of care and working on coordination is to overcome that fragmentation, to minimize it for the patient and the team. Making it again more specific to what we're talking about here today, I want to take this really lovely, colorful diagram from physical medicine and just key off of a couple spots here that relate the most to coordinating care across the continuum. I've circled in orange, we understand the patient's needs. Over to the left, addressing gaps. This is part of the function of the team. And finally, on the bottom right side, I've highlighted communicating and guiding the team, all these team things that we're putting the pieces together. We're trying not to let patients fall through the cracks. And these are very relatable to anyone involved in coordination of complex care over time. But bringing together the ideas of a continuum of care in this setting and coordinating care, I would like to highlight 5 areas where there can be important bridging between these concepts of the continuum that is actually the whole that is happening and the way that the activities to coordinate it could happen. So we'll go through this, one by one, but just to highlight and orient you, the gaps, fragmentation, what that is, how to think about that, the idea of entities that are involved, another idea of transitions and what needs to be managed in transitions, thinking about measurement and how to get a granular sense of what's going on from a coordination perspective. And lastly, drilling further into that on dimensions of teamwork and communication. So starting with the gaps, this is the whole point of trying to coordinate, is trying to reduce the white spaces between either care teams or activities. Like down at the bottom, you have a medical history or test results. You have places like long-term care. Mental health care might not be so applicable here, although it's worth thinking of anything that could possibly be applicable. And I've added on this in more recent iterations of this visual expression of care coordination and the gaps, insurance, obviously for patients and for the team, how care gets paid for also needs to be coordinated. In the middle is the idea of meeting the patient's needs and preferences and delivery of high quality, high value care, and taking all the perspectives into account. So this is, agnostic to particular clinical domain. It can be drawn for any group, and the whole point is to notice the white spaces. And the second feature of bridging between the continuum of care and coordination of care concepts is to think about the healthcare entities that are involved in the specific model of care that we're talking about. So if this is being applied to a different environment, to your own healthcare system, exactly what are the entities and how can they be thought of from the perspective of the patient and the family? How can they be thought of from the perspective of the healthcare professionals involved, all of them? And how might they be viewed, the entities and what they're doing to coordinate care, from a systems representative, the leadership, the frontline, group together as auditing what they're doing and taking that perspective of the whole that's being worked on. But outside of unified systems, the pictures gets much more complicated. And of course, that's what we're talking about. And that's why the details matter. And what we've been hearing about today makes a big difference. The third bridging feature, as you're thinking about scaffolding for implementing, is considering the idea of transitions management. Again, this is about where can fragmentation happen? Where can white spaces happen? There's transitions between entities in the healthcare system. And some of this may seem very obvious, but if you don't actually sit down and say, we have to map out where are all the places that someone has to go, whether it's from room to room or whether it's across streets or now in virtual space. The entities in the healthcare system is where information is transferring, where people are moving, and managing all those transitions becomes vital to keep the coordination as smooth as possible. The other element of transition management that's significant is transitions over time. And that is vital. Again, here we're talking about care that goes on for many, many days, weeks, months, even years. And so considering where the transitions are over time as the patient's intensity needs to either increase or decrease, all of the precision and customized work that's part of this model is occurring over time. So that's another target for bridging. And this is just laying out, what everybody here knows about, but there are areas of setting and type of care in this domain. The fourth area to highlight in terms of bridging is the idea of measuring coordination itself. So we've been talking about measuring clinical outcomes, measuring functional outcomes, but what can be measured in terms of the experience of coordination and the benefits and the problems with coordination? So the work that my team's done has included looking at the landscape of measurement in this domain. And we have seen from what's actually measured in this domain that there are these three perspectives that were on that diagram also in that triangle at the beginning of looking at the gaps, that the patient or the care partners, family and friends have one experience and view of what's going on in terms of how those gaps are being managed, how the white spaces are being managed. The healthcare professional team, individuals on that team and teams together have a view that's very important. I mean, if you get the care coordination going very smoothly for the patient, but you're having to, kill yourselves, that's not actually coordination. Coordination is that it's working well from that perspective. There's also aspects of what's being done for patients that they may not be aware of and that are very important to their well-being. So this perspective is no perspective is more important than another perspective in terms of actually achieving coordination for a high-performing healthcare system. And lastly, like I was mentioning before, there would be this idea of a systems representative. So the administrators, the leaders who maybe are deploying some of the resources, financial or otherwise, and who could respond in terms of how the coordination efforts look from their perspective. And the other way we can think about measuring the coordination of care requires asking, what are these domains that we've measured? We've thought about the perspectives of whose perspectives matter. Now, I'd like to call your attention to thinking about the activities. And this is a list that we developed through a long process of expert consensus and literature, that there's, and this is agnostic to the area, but again, a helpful way to think about what we're trying to achieve in terms of the target of actually doing a good job coordinating. So there's a certain need to know who's accountable for what and negotiate that. Lots of communication. That might have been one of the words you chose when I showed you the word cloud. Facilitating transitions as a key feature that was just discussed. Assessing needs and goals. This is something that happens over time. It's not a static process. A proactive plan of care is a common feature of coordinating care, and so forth. The last one I also would call your attention to, because this model, the model that we're talking about, the SI model, does a great job of thinking about aligning resources that exist within an ecosystem of healthcare entities with the patient, with specific patients' needs, but also thinking at a population level, thinking about the idea of different groups at different intensities and trying to flip that triangle that we've been seeing. In terms of the measurement space, if you wanted to grab a measure to use to give some line of sight to how well coordination is going, we found over 100 measures in our work and created an atlas of measures. But I want to call your attention to one area that has a real gap in terms of measurement, which is the fourth down on the list, facilitate transitions as coordination needs change. Since this is a strong feature of the patients that we're talking about today, the fact that there aren't so many measures in this space that highlight this area is important. And so I want to move to showing you a measure that I think is very powerful and that's being used actually at Hopkins in the Brain Rescue Unit at this point, and reflects the idea of teamwork under complex and uncertain and interdependent conditions. And I'm going to particularly point out this concept of relational coordination, describe what that is and how it can be useful in thinking about what happens in coordinating and also being able to measure it and improve it. So it starts with the idea, again, similar to the white space, that there's the challenge of coordinating across different functions, but instead of including, say, history taking or assessment, this is the people who are in roles. And the challenge is to have all the ties between the role be as strong as they need to be to produce the coordinated care that's desired across time and place. And as you can see, I mean, this is challenging. I mean, this is the idea of, getting everyone on the same page. We've heard about that could be a challenge in any environment, but being able to articulate what are the roles is the first step of thinking from the idea that there are different groups that are coordinating. It's not just individuals, it's people who are part of different groups, and that can be laid out, it can be mapped in a way like this. And then the relational coordination construct is an idea of communicating and relating for the purpose of task integration. And it was something that was developed outside of healthcare, first by observing the airplane industry and a couple air carriers, and how the various functions were coordinating and either getting better or worse performance outcomes that appeared to be connected to the situations of either better relational coordination on the left side of this or worse relational coordination. And the worst side is something that everyone has experienced at some point, where the goals are so functional that there's not a way of seeing the bigger picture and having shared goals, or they have exclusive knowledge that's not shared so much. Many reasons for that. Sometimes it's just time pressure, and any lack of respect in the process of trying to, be part of a team can have detrimental consequences. So mutual respect is another quality of better coordination. That's the sort of the relational side. And then on the communication side, if communication's infrequent or delayed or inaccurate, or if there's blame going around, that also tends to correspond to worse outcomes. And frequent, timely, accurate problem-solving coordination corresponds to better performance. This is just a topology, but these are also dimensions of the measure, the relational coordination measure, which is a 7-item validated tool that's looking at the network of ties, those dyads between roles. And so the work group is part of the measure, and interdependent tasks are part of the measure. And I'll show you how this works on the Brain Rescue Unit. Give a few examples of that from the group there that I've been working with. It works across domains, and there's been really significant research on this type of measure and construct. This just extends what I was talking about a little bit before in terms of what these shared goals, shared knowledge, mutual respect really means, the extent of each of these qualities of the role-to-role relations that are enacted and elaborated by the actual people in the roles, and the experience of those on the receiving end. And similarly with communication, the construct is set up to ask people about whether they're getting enough communication frequently enough, timely enough, accurately enough, problem solving to do the task that is under consideration for the measure. So in the Brain Rescue Unit, we developed to use this measure and to think from this perspective. We identified the main roles that we thought were important for the work that was being done on the task that was under consideration, which you'll see in a minute. And people in the roles were asked the relational coordination questions in connection to the task. So you can use this measure, and I like showing how this measure works because it's a way, even if you don't use the measure, it's a way of thinking about the work that needs to be coordinated. So this underlined part, the patient's care plan for the day, is something that a work group that's trying to assess how well they're coordinating can work together to even say, what is it we are together needing to do interdependently? How would we specify that? How would we ask each other about whether we're getting what we need to do this work that we are interdependent on each other to do? So in this case, the patient's care plan for the day, do they communicate with you in a timely way about the patient's care plan for the day? So one role is being asked about another role. If I'm an advanced practice nurse, I'm being asked about, whether the attending physicians are communicating with me in a timely way about the patient's care plan for the day, so that you can think about these whether you use the measure or not. And if you're using the measure, then it comes down to, for each role, you're getting a range from like constantly to never on these kinds of dimensions, these 7 dimensions. And ultimately that leads to being able to get a visual map, if you use the measure, that is for that task target and the roles that were articulated in the measure. And there can be stronger ties between groups where the 7 aspects are at higher levels, and there can be weaker ties between groups. And weaker or stronger isn't necessarily good or bad. It's a way of visualizing what's happening. I mean, if there's a weaker tie, it may be that there's actually not that much that needs to happen between those ties, but it's still worth checking, because if somebody has said, well, yeah, I'm not getting what I actually need to do this shared task, it might mean that their role isn't considered as much. And so this is a chance to kind of diagnose what's going on between roles. And what's really powerful about this concept, and what I like to highlight, is that there's a whole model of what you can do to improve it. And since there's lots of evidence that shows that teamwork articulated this way for the purpose of coordinating care corresponds to performance outcomes, quality, safety, efficiency, the workers' well-being, learning, innovation. It's been connected to many of these performance outcomes inside and outside of healthcare. We now need to think in any context. So for this, implementing this model in your environment, some of the specific, like you can think of this diagram as a checklist almost of what kinds of features in terms of the structural side of things that middle and top leadership would be involved in are set up to support and enhance relational coordination, and what might be impeding that. So you'll see on this list of structural interventions, many ideas around sharing. So sharing rewards, having shared accountability, and then boundary spanning and shared meetings, shared huddles, that lots of ideas around what structurally needs to happen to have a shared understanding and a shared purpose on the effort that's trying to be made. Down in this, the green areas are more zoomed in. So there's lots of relational intervention ideas that have been developed over time. And I just show one of them, which is this idea of relational mapping. That's the idea of taking these roles and mapping them out, how they're working together and being able to see the strengths and weaknesses of the dyads between roles. And then work process interventions. So being able to assess the current state and being able to see the desired state, which we've been seeing today, the potential desired state, and then experimenting, with the processes to close that gap and using the specific experience of others and seeing if it works in your environment. And that these green boxes are happening, at the front line with workers, and they can be partly elaborated with the co-producing patients and care partners as well. The main message here is trying to understand what's influencing this middle box of relational coordination, and then thinking of that from a perspective of intervening. And it can be intervening with the entire model, like what we've been talking about today, or it can be, picking and choosing based on where the highest need is and the greatest possibility for actually implementing. And I want to end, if we're evaluating the stroke care system and thinking about using the types of concepts I've been talking about, they are all helpful, but the North Star, I think we all agree, is always the patient and caregiver view. So I just really liked this particular picture of how patients and caregivers are having to navigate different places and different aspects of their progression over time. I'll leave it with that. And if we have time for questions, great. And if we don't, I'm always available to be contacted, and I'm delighted to be here today.